Hi guys, good morning. Evelyn, Cassian, thank you. If we can replicate what we did on Tuesday just by you guys typing your name into the chat, wonderfully appreciated. It definitely makes it way easier. Way easier.
Professor, I got a quick question. Professor? Sure.
All right, last few people I think just jumped in. Okay, so before we get rolling today, Deshaun, I did not hear you if you asked me a question. You are still on mute, but
Yeah. Hello? Hello?
I hear you. I don't know if she can or not.
okay. Try it now.
Hello?
Hi, Deshaun. Sorry. Were you guys able to hear me that whole time?
Yeah.
Weird. Okay. Sorry about that. Go ahead, Deshaun.
I just had a quick question for the it's returning to lab. The labs that are are they still due tomorrow or they're due today? Because on D2L they're due today.
Tomorrow.
Okay.
Tomorrow.
Thank you.
You got it, of course. Okay. So if anyone had any questions on, oh, I see why the due date's like that. I'll change that. Fix it. If anyone had any questions or concerns on your grade, whether it be for lab or for lecture, please do not wait until finals week to ask. If you are concerned about your grade and you want to try and do something to fix it, please come to me earlier than later. So, because we still have about a month left of school, so you do have a chance to bring your grade up. However, if you are very concerned about it, I advise you to please come talk to me ASAP. We can schedule an appointment. We can Zoom. I can give you some advice on what is kind of coming up that might be able to help your grade. So I definitely advise you to take care of that ASAP. Waiting till last minute is not going to help you. If anything, it's almost a lost cause. I hate to say it, but if you wait till last minute, then it's not going to do anything. Okay. Any other questions pertaining to, so anyone who did just jump in, if you did not put your name into the chat, please do. It's my definitely new and easier form of attendance. All right, we are going to get going with our lower leg, ankle, and foot. Just to continuously let you guys know, as I mentioned on Tuesday, your next exam is due Tuesday. I'm sorry, is Tuesday the 24th. We are going to be taking it in person, or quote unquote in person during class time. Okay, so Tuesday the 24th is our next exam, and it is going to be on the lower extremity muscles. And your second set of flashcards are also due. Okay, so you have about a week and a half, a little over, in order to start preparing. So do what you have to do, make appointments with me, make appointments with our tutor, Brianna Montoyo, to begin preparing. But the earlier you start preparing, the better.
When you mean in person, you mean like on Zoom, right?
Yeah, I said in person and I thought about it, I was like, that's dumb. During class time is what I meant.
Okay.
Any questions on that? Okay, cool. So today we're just going to be briefly starting the lower leg, ankle, and foot. It's going over some basic anatomy, a lot of information you guys should already know, talking about our joints and some of the more important structures. On Tuesday, we should be hitting the musculature. So if we get to muscles today, I don't think we will, but if we do, cool. If not, we'll begin those on Tuesday. Okay, the ankle and the foot. So let's talk a little bit about our bones. In the ankle and the lower leg and the foot, there are about 26 total bones combined. Now, if you guys remember from our upper extremity, we have 27 bones in our hand. Does anyone know what the difference is between the amount of bones we have in our ankle, on our foot and ankle versus our hand? don't know if you remember from A&P. Okay, so in the ankle and foot, we have 26 bones because we only have 7 tarsal bones. How many carpal bones do we have in our wrist? Okay, very good, Alex. 8 carpals versus 7 tarsals. Excellent. We have 7 tarsals, our calcaneus. Our calcaneus is also called our heel bone. So everyone should know what their heel is. So calcaneus is our heel. We have the talus or talus, and this is probably one of the most important bones since it is our connector to the entire lower leg. The cuboid, our cuboid is the most lateral tarsal bone. The navicular, our navicular plays a very important role since it's very big with our structural attachments. So a lot of ligaments, a lot of our arches in the foot, muscles, all attached to our navicular. And then we have our medial, intermediate, and lateral cuneiform. So 1, 2, and 3. Medial is considered to be the first. Intermediate is the second. And the lateral is the third. And then just like with our hand, we have 5 metatarsals. The metatarsals are these nice long bones that connect our tarsals to the phalanges. And then we have 14 phalanges. Remember, the big toe is just like our thumb, and it is missing this middle phalange here. It only has a distal and only has a proximal. So here's kind of the breakdown of our foot and regions. So we have the forefoot, and this is important for our athletic training majors because we hear and learn about a lot of injuries that pertain solely to the region. We also hear of a lot of structural abnormalities that also pertain to the region. So in our forefoot, that is where our phalanges and the metatarsals are located. So this is basically the quote unquote front of the foot. And it also happens to be the most distal segment of the body. Our midfoot, notice our midfoot is just tarsals, and I'll change the color quickly. And it is the tarsals that sit directly in the middle. So our cuneiforms, 1, 2, 3, our cuboid, and the navicular. And then lastly, the hindfoot region is the back of our foot and ankle. So think of hind, like behind. It is behind us. And that is our calcaneus and the talus. So hindfoot, midfoot, and forefoot regions. Again, these are important to know. I'd say more for our structural purposes, knowing what forefoot valgus versus rear foot valgus. So there's a lot of different structural components that involve these 3 regions. Okay, so here's just kind of a really good view. Our metatarsals and our phalanges, as we know, are the most distal segment of the body. And again, these are in front of us. So it is the anterior section. Posterior, aka our hindfoot, the posterior segment is where our calcaneus is. It's behind the foot. Now, dorsal and plantar. I know we've talked about these before, and you may have talked about them in other classes, but the dorsal, remember, dorsal means the back. So the top of the foot here is the dorsal aspect of the foot. Think of a dolphin. You guys have heard dolphins and whales with a dorsal fin. So the dorsal fin would sit on the back, just like on top of the foot. And then the plantar is the bottom of the foot. And best way to remember plantar, if you are walking in grass, what part of your foot hits the grass? It is the plantar. Plants, think of like grass under your feet, plantar aspect. Okay. Any questions on these directions for the ankle and the foot? All right, cool. Yikes. I'm gonna fix that really quickly. It's gonna bother me. So now talking about different functions of the foot, we have the main function of our foot is to be weight bearing. And that's because all of the weight of our body, it comes down and it sits on top of our foot. So the entire weight of the body gets transferred down the tibia and it ends up transferring all throughout the foot. Okay. Okay, so weight bearing, number one function. As I just mentioned, the weight travels down, the weight of our body travels down the tibia. So it comes down like this. And what bone articulates with our tibia? Who remembers what bone articulates with the tibia?
That's rectus femoris.
No. What bone in the ankle articulates with the tibia? The talus. The talus articulates with the tibia. And so that weight comes down the tibia, gets transferred into the talus. And then after it hits the talus, the weight actually continues down into our heel. And that's where it gets dispersed to the sides of the foot. So tibia, talus, calcaneus is where weight gets transferred and force gets transferred down the leg. Shock absorption. So another important function is shock absorption. So when we are walking, whether it be on smooth surface or uneven surface, we're always going to be interfering with some form of shock or some sort of force on the ground. So now it's the opposite. Shock will travel up. And we need the calcaneus and some of the ligaments and fascia on the foot to absorb some of that shock. And then lastly, locomotion. Locomotion means walking. So the reason our foot looks like the way it does, it's being the foot and ankle. And the reason our ankle is at hinge joint is in order for us to walk properly. So here's actually a really great picture. Here's that tibia articulating with the talus. The fibula has minor articulation here, very, very little, but the main articulation is between the tibia and the talus. When we combine tibia, talus, I'm sorry, tibia, fibula, and talus, we get the ankle mortise. So if any of you are in lower yet or prevention and care with Dr. Vanek and Dr. Shotwell, ankle mortise, you can really impress them by knowing the answer to that. So all three of these together create the ankle mortise. It is ideally a hinge joint. So what are some other hinge joints we've seen in the body? What are some other hinge joints?
Elbow.
Okay, the knee. Great job, guys. The knee and the elbow. Excellent. Knee and the elbow are two different hinge joints. And we know the motions that occur at our hinge joints are going to be flexion and extension. So the same motions occur at the ankle, but they are called different names. So your standard flexion, remember flexion is anterior, it's coming towards the body. Dorsiflexion is the same as regular flexion. Plantar flexion is when we come down basically into extension. So plantar flexion, the bottom of the foot is going posteriorly. So it's just like extension, but it's called plantar flexion. Always remember, P in plantar flexion, P as in pointing your toes. So when we point our toes and our ankle, that's when we are performing plantar flexion. Dorsiflexion, we bring the whole foot and ankle anteriorly back towards the body. So all of you right now, I want you to go into full dorsiflexion, and I want you to go into full plantar flexion. Which motion do you have more of, plantar flexion or dorsiflexion? Cassiana, really? That's really interesting. Okay, so those of you who have answered, out of everyone, we only have 2 people who have more dorsiflexion than plantar flexion. I want us to think about this and kind of break this down. The reason that they have more dorsiflexion motion is for one of 2 reasons. A, your calf muscles are super loose, so it's relaxed enough to let you get full dorsiflexion. And B, the second reason you might have more dorsiflexion is you have a lot more space in this ankle mortise here. So most people, it's so tight in this joint, they are not able to fully dorsiflex. But if you, we had Tamara and Cassiana who had a lot of more dorsiflexion, that means that there was way more space in the joint instead of it being a lot more tight. Those of us who have more plantar flexion, so they have more motion when they are pointing their ankles and toes. That generally indicates that it's more normal to have more plantar flexion. And that's because when you go up into dorsiflexion, it's usually a bony block. So therefore, you're able to get more motion in the opposite direction. So more plantar flexion is much more common. Those of you two with more dorsiflexion is very interesting. And kudos to you. That's a great quality to have. Does anyone Nas, plantar 100%. Me too. My dorsiflexion's terrible. For Tamara and Cassiana, you guys are probably your squat, when you perform squat, like any type of squat, you should have very good squat form because it requires a lot of ankle mobility, especially in dorsiflexion. So keep that in mind. Okay, the next joint we are going to look at is the subtalar joint. So that is between our calcaneus and the talus. Subtalar, sub meaning below. So the calcaneus is below the talus. This is actually a nice picture to point this out really quickly. So the force, when our weight-bearing force comes down our tibia, it goes down the talus and it comes out to our calcaneus. Calcaneus, as you guys should know, the calcaneus is the thickest and widest tarsal bone. It's very large, it's very thick, and that's because of all the force and the shock that it has to absorb. So the subtalar joint is responsible for our inversion and eversion. Inversion and eversion. So inversion, we usually get anywhere between up to about 30 degrees of inversion. But for eversion, we normally only get to 18 degrees to 20 degrees. Why is that? Why do we have so much more inversion as opposed to eversion? Why do we have more motion when we perform inversion? Okay, Mallory, what about the medial malleolus? So, does the medial malleolus block us from going into eversion? Let's think about that. Here's our medial malleolus. Here's our lateral malleolus. Okay, so the lateral malleolus blocks us from going into eversion. Lexi, yes, the ligaments on the medial side, we have a ton of really strong ligaments. Now, the ligaments on the medial side also prevent us from going into full eversion. So the lateral malleolus and the medial ligaments prevent eversion. So therefore, we have way less eversion. Inversion, that medial malleolus is sitting up here. So it's a little lower, but medial malleolus is not blocking us from inverting, right? We're bringing the whole foot and ankle inward medially, and that malleolus is not going to stop us. That is why we get way more inversion ankle sprains. So if anyone has ever sprained their ankle, the most common mechanism of injury is forced inversion. We invert our ankle more frequently, and there is not much structurally that's going to stop us or prevent that excess inversion. We have our 3 lateral ligaments that I'm just representing the 3 that kind of help, but it's not enough. That is why we have way more inversion ankles. Yeah, both sides are common. That means it's pretty more severe cases. Both sides are torn, which is terrible. But most common type of ankle injury is an inversion ankle sprain. So that means we are injuring the lateral side by inverting. So I want you all to invert and evert right now. When you invert, I want you to feel where there is a stretch in your ankle or foot. So invert. And I want you guys to tell me, where do you feel that stretching? Another good way to do this is to passively invert your ankle. So if you are to passively invert your own ankle, so doing it yourself, not an active contraction, you should feel a stretch on the lateral structures. So you should feel a nice stretch from the lateral side when you passively or actively invert. And that's because our ligaments on the lateral side are trying to protect us from this excess motion. When we evert, so when you go into eversion, you should feel a slight stretching on the medial side. And that's because those medial ligaments are trying to stop us from going into excess eversion. Does that make sense to everyone? The ligaments on the opposite side of the motion are trying to protect us from that excess motion. So if I'm bringing my foot and ankle out laterally, those medial structures are trying to stop us. And again, passively play around with your own foot and ankle. You should be able to feel it. Okay, other joints that we will talk about are the intertarsal joints. So it's the joints between each of our tarsal bones. The metatarsal phalangeal, aka the MTP. The interphalangeal. So metatarsal phalangeal is between our metatarsals and our proximal phalanx. The IP joints, so we have our DIP, PIP, and regular IP, are between our phalanges. So the proximal phalange, when it articulates with the middle, I'll go back to a picture, show you. Okay, so here is our proximal phalange. When the proximal phalange articulates with the middle phalange, that's called the PIP joint. When the middle phalange articulates with the distal, that is called the DIP. What is the name of the joint between the proximal first phalanx and the distal first phalanx? What is this joint called right here? Because remember, our big toe does not have a middle phalange. Anyone? Really? So this joint is called the IP joint. It is very simple. It is the IP, not the proximal, not the distal. It is the interphalangeal. Okay. The last joint I did not talk about or mention before is this joint between our tarsal bones and our metatarsals. Tarsals and metatarsals. That is the tarsometatarsal joint, the TMT joint. So let's talk about some of the actions at these joints. So the intertarsal, what motions occur between one tarsal bone to the other? What motions occur? So intertarsal joint, what motion? Okay, very good, Tyler. It is a gliding joint. They simply sit and they kind of glide on top of each other. They do not move in a plane of motion. So there is no axis for these joints. So for example, between the first cuneiform and the second cuneiform, they basically sit kind of right next to each other. They glide on top of one another. So that is the intertarsal joint. How about at the MTP joint? So where our metatarsals meet the proximal phalanx, what motions occur at this joint? I'll give you a clue. I'll give you the actions and I want you to tell me what joint classification. So at the MTP joint, we are able to perform flexion, extension, abduction, and adduction. So what type of joint is that? Guys are killing me. It is a condyloid joint. So the condyloid or an ellipsoidal joint means it has two axes. So it has movement in the frontal plane and movement in the sagittal plane. So that's the exact same thing for our MTP joint in our foot. Performs flexion, extension, and abduction and adduction. So it is two axes and it is a condyloid. How about our IP joints? It only performs flexion and extension. So for our IP joints, it is a hinge joint. Oh, very good, Mallory. It is a hinge. So it only performs flexion and extension. Okay, so these are good to know what type of actions, because once we get to the muscles, we can put two and two together. The muscles plus the actions that they are performing and help you kind of visualize how these bones are moving. So two joints we didn't really talk about when we did the knee. We have our proximal and our distal tib fib joint. So the distal tib fib is what we're really going to focus on right down here. The distal tib fib is a synchondrosis joint. Synchondrosis. Therefore, it is not a synovial joint. Remember, synovial joints mean there's a lot of movement. A synchondrosis joint or syndesmotic is an amphiarthroidal joint. Who can tell me how much functional movement do amphiarthroidal joints have? Synovial joints are diarthroidal. So how much movement does a amphiarthroidal joint have? Okay, so amphiarthroidal joints have little to no movement. Little to no movement. So this really thick, fibrous connective tissue, it's connecting the bones, and then it continues up the length between our tib and fib. So you guys have probably heard of a high ankle sprain before. Yes. So a high ankle sprain is also called a syndesmotic sprain. And that is indicating a sprain at this particular joint. So syndesmotic sprain is a sprain at this joint. If you've ever had a high ankle sprain, they're extremely painful and they usually take a long time to heal. And that's because the joint is not supposed to really move. Amphiarthroidal means it does not have a lot of movement. So this is not supposed to move. So if we sprain this joint, that means we moved it too much, enough to the point to cause damage to this tissue. So that is also called a high ankle sprain or a syndesmotic sprain. Now, who remembers the name of this connective tissue throughout the tib and fib? We also saw this for the radius and the ulna. What is this tissue called? So this is interosseous membrane. So this thick fibrous connective tissue is called interosseous membrane. It is also located between the radius and the ulna. Okay, any questions on these joints? Any questions between these joints and the movement? All right. So the last thing we're going to cover is going to be our ligaments in the ankle. We're not going to get to the muscles today. I'm just going to leave that for Tuesday. So we're going to talk about our ligaments in our foot and ankle. So the lateral ankle has 3 main ligaments that we need to talk about. Remember, as Lexi mentioned earlier, ligaments also prevent the bones from going too far or creating excess motion. So ligaments' main job is to prevent excess motion. As we know, it also connects bone to bone. So on the lateral ankle, we have the ATF, the CF, and the PTF. So the ATF ligament reaches from our fibular head and it comes down to articulate with our tarsal bone. So it connects to part of the cuboid and part of the navicular. So ATF and talus, I apologize, goes from the fibular head to part of the talus and navicular. When you guys are palpating and you learn your palpations, the sinus tarsi is a kind of a hole. The term sinus means a groove. The sinus tarsi is a groove located right near your lateral malleolus, and the ATF ligament runs directly over the sinus tarsi. And what happens is when we sprain that ligament, we get a lot of point tenderness directly over the sinus tarsi, and that's indicating a sprain to the ATF. The next ligament is our CF, which is the calcaneofibular ligament. So the CF goes from our fibular head to the calcaneus. So it comes straight down like this. ATF is right here. And then lastly, our PTF ligament is posterior. Not a good view. Let's see. Here we go. Still can't really see it very, very well. So the PTF ligament comes down from the fibular head to the posterior talus. So there's still no good image of it here. So it goes from the fibula to the posterior talus. So that is our PTF. As you can tell, these three ligaments, they're kind of spread out. We have 1, 2, and then the third one is kind of back here. So they're spread out. So that's why they don't really help prevent a lot of that inversion motion. So when we invert, we are putting all of these ligaments on a stretch. These three are supposed to help us prevent excess inversion. What is one thing you notice in common between all three of these ligaments? What is something that all three have in common? Okay, good, Tamara. The fibula. They all originate off of the fibula. So they go to different bones, talus and calcaneus, but they all are from the fibula. Excellent. So on the medial side, our medial ankle ligaments come from the tibia. So they go to different bones, but they originate from our tibia. So our medial ankle ligaments are called the deltoid ligaments. Deltoid means 4. And we have 1, 2, 3, and 4. So the deltoid ligaments, if you put a 4 up with your fingers and then turn your hand to put your fingers up against your medial malleolus, that's the direction these ligaments go in. So they replicate the 4 fingers. So 1, 2, 3, and 4. Okay, so medial ligaments, there's 4 altogether. They're called the deltoid ligaments. We have the tibiocalcaneal, so going from the tibia to our calcaneus. So tibial calcaneal, posterior tibiotalar. So here's the posterior tibia, and it runs from the posterior tibia to the posterior talus. Tibio-navicular, so comes down, inserts on that navicular, and then the anterior tibiotalar. So what all four of these have in common is that they originate from the medial malleolus. So what motion at the ankle are these ligaments going to help prevent excess of? Eversion, excellent, Cassiana. So when we evert the ankle, our deltoid ligaments are working to help prevent excess motion. They're going to be put on a stretch. Very good. Next ligament is our calcaneocuboidal navicular ligament. It is the worst name for a ligament in the world. It is a mouthful, an absolute mouthful. So the calcaneo, it has in the name right here exactly what bones that these that this ligament connects to. So it goes from the calcaneus to the cuboid to the navicular. Calcaneus, cuboid to the navicular. And this is called a bifurcate ligament, meaning that it splits. So it comes off of the calcaneus and it splits to go to the cuboid and the navicular. And the purpose of this ligament is to prevent movement of our proximal tarsals. So what tarsal bones would be considered our proximal row of tarsals? So the proximal tarsals proximal tarsals, calcaneus, talus, navicular. Our cuneiforms and the cuboid are all considered to be distal tarsal bones. So the calcaneocuboidal navicular, it comes off of the calcaneus. So it starts kind of like this. And then it splits. Goes towards the navicular. Goes towards the cuboid. And again, it stems off of that calcaneus. Okay, some movements that we did not talk about before were pronation and supination. So pronation and supination are definitely the easiest to assess and almost the only way we're able to assess in a weight-bearing position. So that means we need to be standing in order to properly supinate and pronate. So if you guys were to stand up right now, and if you do your best to put your weight of your body equal in the center of your feet, if you were to stand and shift all of the weight in your feet to the inside, that is pronation. So all of the weight of your body is shifting to the inside of your foot. That is technically, you're technically everting your ankle and you are abducting your foot. So pronation is a combination of those. Supination, so if you try and keep your weight equal and you shift your weight to the outside of your feet, that is supination. And if you look closely, that it looks like you are inverting the ankle and your foot is adducting. So pronation here, take a look at the ankle. It is an eversion. And the foot is kind of going out laterally into abduction. So that is pronation right here. Pronation also leads to pes planus. So when we pronate, we have pes planus, which is flat foot. Think of the plains like out west, the plains like fields, they're flat. So pes planus remains flat. This normally indicates that the ligaments in our foot are weak and they are not supporting the tarsal bones very well. In supination, so here we are looking at supination. Check out the ankle and let's change this. At the ankle here, they're in inversion, and even the foot is coming in medially into adduction. So that is representing supination because all the weight is kind of falling to the outside of the foot, resulting in inversion at the ankle and adduction of our foot. The arches, so when we have someone who supinates or is in natural supination, they normally have pes cavus. Pes cavus is a high arch, and it literally looks like a cave. The arch goes up so high, it looks like a cave. Anyone here have super severe pes planus or pes cavus? A lot of times our dancers and our gymnasts are known to have some pretty high arches, but I'm very curious, anyone here? Okay. Okay, so the last portion of these ligaments technically count as ligaments are going to be our arches. So for the subtalar joint, where that here we have our talus articulating with our calcaneus. Something very important that helps support this structure. Oh, Evelyn, she does dance. Yeah, it's very, very common. Dancers and gymnasts have very high arches. Excellent. So the first arch is going to be our longitudinal arch structure. So the longitudinal arch, we have a medial and we have a lateral longitudinal arch. So the medial spans all the way from that first metatarsal here, all the way to the back of the calcaneus. And that's the medial because it is on the medial side of the foot. The lateral goes from the base of the fifth to the calcaneus. Who can tell me what plane, so what plane of motion are the longitudinal arches parallel to? So what plane of motion goes from anterior to posterior, just like these arches? Very good, Tyler. Ooh, sorry. Very good, Tyler. The sagittal plane. Remember, the sagittal plane cuts the body into down the middle. So the sagittal plane, think of these arches cutting the foot. It's going from front to back. Sagittal plane goes from the front to the back. Excellent. And then we have our transverse arch, which we're going to look at in a second as well. The transverse comes across from lateral to medial. So the transverse arch starts on the lateral side of the tarsals and comes all the way to the medial side. So it's supporting all of our tarsal bones right here. If we were in person, something we usually try to do in lab is create wet footprints. And if you ever walk around at the beach, at a pool, on a deck, anywhere after swimming or being somewhere wet, and wherever you walk and you get a footprint, you can actually be able to tell if you have high arches or if you have flat feet or low arches. So next time you're walking around somewhere where you leave a footprint, take a look to see if you can get an idea of what type of arch you have. When we are flat-footed, since all the weight of the body is coming down this way, it's filling up this whole space. Whereas the high arches, the only area that the foot is making contact with the floor is under the metatarsal heads and along the lateral side to the calcaneus. Oh, I talked about the transverse arch. Yeah, so for our longitudinal arches, I mentioned lateral, longitudinal, and medial longitudinal. And again, these arches are crucial for supporting the structures of our foot. The whole weight of our body is coming down to this final segment. So our arches play a very important role. When we see that someone has hip pain or knee pain, a lot of times we have to start thinking outside the box and kind of analyze, like, okay, I wonder how their arches are. Most of the time you have to go to that length for deductive reasoning to see if that could be a causing factor. So for the longitudinal arch was we have the medial and the lateral. And again, they fall in the sagittal plane. We have ligaments that support our longitudinal arch. We have our long plantar ligament. So the blue, we'll get rid of this green line. The blue dot is indicating where our long plantar ligament is. We have our short plantar ligament. So the tiny area where this yellow dot is. Long plantar is pretty lengthy. And then we have our spring ligament. So the spring ligament goes from the calcaneus to the navicular. So the spring ligament goes from our calcaneus, like this is a protuberance on our calcaneus, to the navicular here. The spring ligament is probably the most important ligament for our longitudinal arch structure. And it's also important, it plays a very, very crucial role in supporting the talus. So when we are standing up, the force of that talus, it wants to either go straight down into the calcaneus, or it wants to go straight, kind of continue going inferiorly and anteriorly. That spring ligament right here helps support the talus when we are standing. Here's actually a pretty good ligament, image as well. Long plantar, notice it is very, very lengthy, going from the calcaneus to the base of our metatarsals. Short plantar, and then our spring ligament. Underneath, they may have retracted it. Underneath, we should have been able to see from this picture, you can see that they cut it, would have been our bifurcate ligament, and that's that plantar cuboidal-navicular ligament that I mentioned before. And I'll kind of draw it really quickly. So the plantar calcaneo-cuboidal-navicular, again, comes from our calcaneus, comes up, and it is going to split, go towards the cuboid, and then split. Shoot, sorry, it splits this way. It's too far up. So that again is that plantar calcaneal cuboidal navicular. Headache of a name. It's that bifurcate ligament that splits off. Okay, we are going to end here, and I'm going to pick up with our muscles. So we're going to start with our plantar fascia and go into our muscles for Tuesday. All right. If you have any questions, feel free to ask. If not, I hope you all have a wonderful day and a wonderful rest of your weekend. Again, please communicate if you're struggling or if you have any questions, comments, or concerns about anything. Have a great day, guys.
Will do. Thank you, Professor Arundel.
See you in a bit, Naz.
See you in a little bit.
Thank you. Have a good weekend.
Monty.
Thank you.
Hi, Evelyn. Well, I'll see you in a bit.
Yeah.
Bye, Jess. You too.